to welcome you all to today's webinar, Substance Use Disorders Among Adolescents and Young Adults. My name is Jess Samuel, and I'm the project coordinator at IRETA, and I'll be moderating the webinar today. At this time, I would like to go over some housekeeping items for today's webinar. We would like to encourage you all to participate in the webinar. If you have questions for Dr. Wilson or are experiencing any technical issues, please use either the chat box or the questions pane to communicate to us. At the conclusion of the presentation, Dr. Wilson will stop and ask for questions. At that time, we'll read aloud any questions that have been submitted. Again, you can submit questions via the questions pane or chat box. Throughout the webinar, all participants will be on mute. Following the webinar, you'll receive an email with a link to the evaluation and information on how to access your Certificate of Attendance and Continuing Education certificates. This webinar has been approved for 1.0 PCB and/or NADAC credits. You can also request a general Certificate of Attendance. Certificates may take up to 48 hours to appear in your profile, so we ask for your patience. I will go over all this again at the conclusion of the webinar. At this time, we're going to go through two poll questions. We like to get a picture of the demographics of those in attendance. There are no wrong answers. These questions will appear on the screen momentarily. Please select the best answer as it applies to you. I'll give you a minute to go ahead and make your selection. I'm going to go ahead and close the poll now. Everybody will get a notification that you have about 20 seconds left to make your choices. All right, and I just went ahead and shared the responses, and it looks like a majority of people that are on today had checked off other for their professional role, and we have quite a bit of people on today that represent the addiction field. Thank you all for completing the poll questions, and we will be recording this webinar. I would now like to introduce Dr. Deanna Wilson. Dr. Wilson is an assistant professor of medicine and pediatrics at the University of Pittsburgh. Her research interests include reducing substance use-related health disparities with an emphasis on opioid use disorders in adolescent and adult populations. Her work includes integrating harm reduction into primary care settings, developing low-threshold models of care to improve engagement and retention of vulnerable populations, and improving resilience and coping using mindfulness as a strategy to mitigate chronic pain. Okay, Dr. Wilson, if you're ready, I'll hand things over to you.
and young adults. The objectives for today's talk: we will review definitions related to substance use and substance use disorders, review typical adolescent development, and explore why adolescents as a group are particularly vulnerable to substance use. We'll review some highlights from current epidemiology of substance use in teens, identify some key strategies to talk to young people about their substance use, and review how to implement routine screening and brief interventions into clinical practice for adolescent patients. To start with some general definitions. So we're discussing today substance use, so any substance use, and then also substance use disorder, which is a DSM-5 diagnosis. And so the DSM-5 replaces our old understanding or diagnoses of substance use abuse or dependence. And so substance use disorder really, I think, is a nice way to think about substance use because it really kind of talks about it as a spectrum of use. And so the way that you sort of make the diagnosis is you probe for these 11 kind of factors, and then based on kind of positive endorsement, you end up with a diagnosis of mild, moderate, severe. And so, I think of these as three general buckets. So the first bucket is sort of characterizing dependence. And so that's asking questions about tolerance or withdrawal. And so tolerance is really the idea that people report using more and more of a given substance to achieve the same high, and sort of really characterized by neuroadaptations that sort of require an increased dose to achieve the same effect. Withdrawal being a state sort of characterized by negative affective state and physiological changes that result when you no longer have access to a substance that you're dependent upon. The second bucket is sort of this idea of loss of control. So people will talk about using more than they intended, trying to cut down by not being able to, spending more time trying to obtain or use a substance, having increased craving or compulsion to use, and then using despite negative consequences. And so that's really discussing sort of substance use in the setting of struggles at work, home, and particularly in young people really thinking about school as sort of their primary occupation, and so struggling in school because of their substance use. I like this pyramid as a way to think of, not everyone that we'll see, particularly young people who use substances, are going to meet criteria for substance use. So severe substance use, the very small tip of the pyramid. A larger bulk may meet criteria for mild or moderate substance use. But the bulk of people that, I would see in a primary care setting would not have substance use or might not endorse any use. But what we're trying to screen for is identify those who are using sort of substances that place them at increased risk. So an example might be opioids, which sort of increases their risk of an overdose, or maybe using substances in sort of ways that confer additional risk. So that might be someone who drinks alcohol once a month, but when they drink 10 drinks and drink in excess. And so that we know that that heavy episodic or binge drinking sort of confers additional health-related consequences and risk. And so part of our job when we think about screening is to not only pick up those at the very tip of the pyramid who might have severe substance use disorder, but to really think about whether or not we can move further down the pyramid and start to pick up those with risky use before more severe use develops. Addiction is very similar to this notion or idea of sort of substance use disorder, but it's its own sort of clinical entity and really is a complex chronic relapsing brain disease characterized by compulsive and uncontrollable drug craving, seeking, and use that persist even in the face of extremely negative consequences. What I think is really key here is, this describes sort of a pattern of behavior, but a pattern of behavior that is characterized really by structural and functional changes in the reward, inhibitory, and emotional circuits of the brain. And so this is where, behaviors are really written on the brain at large. I think this is a great diagram from Nora Volkov, and you can see the brain. So this is looking at functional MRI. The brain on the left is from someone who doesn't have a substance use disorder. The brain in the middle is from someone who's been abstaining from methamphetamines for a month, and so you can see the pattern at which it lights up is different. And then you can see on the sort of right, somebody who's been abstaining from methamphetamines for 14 months. And so that sort of light up pattern kind of more closely resembles that of someone who doesn't use substances. And so I put this here always as a reminder that while we're talking about addiction being a disease that changes the structural and functional sort of circuits in the brain, that these things are many times reversible and sort of can be improved and changed with abstinence. We'll be discussing about SBIRT, and so SBIRT is a process by which we think of sort of operationalizing screening into sort of primary care and clinical care settings. And so the S is really this idea of screening in clinical settings, then delivering brief interventions, discussing referral options and treatment considerations with patients. And we'll discuss sort of how to do this process in adolescent and young adult patients. There's been mixed evidence looking at SBIRT and sort of how to implement that and the evidence for doing so in the adult population. There's less evidence in the pediatric population, which we'll be discussing today. The next sort of general topic is sort of defining adolescence. So who actually are we talking about? So adolescents are sort of experiencing a period of adolescence. And so really this idea that they're undergoing rapid changes in a variety of domains. So there are biologic and physical changes, the most sort of common or significant of which we think of as being puberty. Psychological and cognitive changes, social and sexual changes. And so when we think of early adolescence, we think of very young teenagers, so 10 to 13 years of age, many for whom are experiencing the first sort of signs and onset of puberty and all the attendant hormonal changes and physical changes that go along with that. We know that there are a number of psychological and cognitive changes. They're very egocentric in this group, and so, we often think of them as, they sort of live with an imaginary audience. And so people talk about this, that they're always thinking of what other people are thinking about them, feeling like they're being watched or under a microscope. This sort of age group is characterized by a lot of emotional lability. They're often very concrete thinkers. So talking about substance use with this age group in particular, asking very specific, very concrete questions. We know that same-sex peer groups often sort of take on additional significance and weight. There's a lot of ideas of group allegiance and sort of protection from one's peers. And there starts to be this shift from being sort of dependent on one's parents to starting to seek out additional means of independence. There's a number of sexual changes that happen as well, and so sort of self-exploration, really this idea of comparing oneself to one's peers. Am I normal? Is this normal? In middle adolescence, we start to see like a slight increase in sort of complex decision-making and logical thinking, but really start to see the antecedents of sort of this impulsive behavior, testing boundaries, and sort of the onset of risk-taking behaviors. That's in a setting of increased independence from parents, increased desire to conform with peers. And so during this time, there's increased precedence on what are my peers doing and should I be doing what they're doing. And so really this idea of, young people who exist in peer groups where there is substance use, we know are at increased risk for using substances themselves. And so, this can be sort of a red flag in the context of a clinical discussion if you hear an early or middle adolescent talk about others in their group who are using substances. Late adolescence and early adulthood. So we used to think of adolescence being sort of restricted to age 18, and then with additional research realized many of these sort of behaviors persist into the early 20s, and so 21 was sort of our threshold. And now with additional neuroimaging data, we realize that the brain doesn't fully develop or mature into the mid-20s. And so think of sort of early adulthood as being, 24, 25. We know that during this time period, you start to really develop logical thinking, the capacity to have abstract thought, and really start to see young people kind of endorse delayed gratification, think through consequences of behaviors, often start to see a realignment of sort of family relationships, and acceptance of not only one's sexual identity, but one's sort of own identity. I think this is a great illustration as a reminder of what's actually happening with the brain. And so you can see this is the brain from ages 5 to 20. And now with the new data, we realize this sort of maturation process really continues until about 25. And so what this illustration shows is the blue areas of the brain are areas that are more mature, more myelinated. And you can see that the brain sort of matures from the posterior portions forward. And so the frontal lobe, the front sections of the brain are the sections of the brain that really help control abstract thinking, complex decision making, that help people weigh consequences, risks, and benefits. And that component of the brain develops much later than the components of the brain that really sort of evaluate reward and get a high from using substances or engaging in risk-taking behaviors. What's also key about this point is that it's not just additional sort of myelination and additional connections that are happening, through the mid-20s. There's also something happening called synaptic pruning. And that's really this idea that not only do more connections potentially happen, but we start to sort of reinforce certain connections, and others sort of are not reinforced and disappear. And so it's through this way that we kind of pattern and reinforce certain behaviors. And so this is one of the reasons why we think sort of exposure to substance use early in adolescence reinforces sort of addictive patterns of behavior and places people at increased risk for developing an addiction later. I always try to explain to the parents of my patients that really thinking about the adolescent brain as a car. And so you have this fully functional gas pedal. So the amygdala can process feelings of reward and pain. That maturation happens early. There's often salience of substance use-related rewards. So young people can experience the euphoria and the high associated with taking a risk or using a substance. But because the prefrontal cortex develops later, and again, that's the front of the brain that can sort of assess situations, weigh consequences, make decisions. They're often weak breaks, and so there's limited ability to really recognize or think through substance use-related consequences. And so the end result is you have a young person who's sort of built to pursue pleasurable rewards, avoid painful stimuli, with really little thought of long-term consequences associated with substance use. And so because of that, brings us to sort of the first real takeaway from the talk is that addiction is sort of a pediatrics disease. And I will say that it is a disease that we often don't think about in that way. But we know when we look at sort of three of the most common substances, so tobacco and THC, or sort of the active component of marijuana and alcohol, that first time to dependence is really sort of ages 15 to 25, so that middle adolescence to young adulthood. And in fact, we know that 90% of those who have an addiction as adults started using substances before the age of 18. 75% of high school students have said that they've ever tried addictive substances, and 12% actually meet criteria for having an addiction. And so while not every young person who uses substances will develop a problem, most of those who develop problems start using in adolescence. And so this time period is one where it's really important to start to recognize the signs of substance use and certainly of addiction early so that we can intervene. Looking at 2017 data from the Youth Risk Behavioral Surveillance Survey, and so that's collected from the CDC and surveys high school students, we see that high school students reported in the 30 days before sort of taking the survey, about a third said that they had used alcohol, about 16% said they had ridden in a car with someone who had been driving. 1 in 5 say that they've used marijuana. 8.8% say that they'd smoked cigarettes, and that number, in fact, has been going down over time. 13% say they've used an electronic vapor product, and it would be interesting to sort of continue. We know that that percentage continues to increase, particularly now there's been a lot of social media coverage and a lot of targeting of adolescents and young adults with products like Juuls, and so anticipate what the next year that we do the survey, we'll start to see even higher numbers reporting exposure to electronic vapor products. I also think what that tells us is we know that, from a peak of about 20%, high school students are choosing to smoke less cigarettes. And part of that, I think, is a reflection that many of our marketing campaigns and educational campaigns discussing the risks of tobacco have really started to sort of make an impact on young people. And they may be choosing electronic vapor products, and some of the research bears this out because they view these as sort of safer alternatives. And so really thinking through, what educational campaigns and strategies work and what are the messages that seem really salient for young people. And we'll talk about some of that later. We know that lifetime use, so about 14% say they've ever taken a prescription pain medicine to get high or in a way different than prescribed by their physician. 1.7% report heroin use, 2.5% methamphetamines, and 1.5% report ever having to inject an illegal drug. And so, I think those numbers are really striking. To put in context, these are young people who are in school on the day that the survey is administered. And so this is an underreport when you think of all the young people who don't make it to class that day or may have left, dropped out of school, who probably have much higher risks of using substances. Also, we know from some of this data that it's not, substance use isn't uniform across all groups, and so sexual minority students have significantly higher rates of nearly all substance use compared to heterosexual or non-sexual minority students. We know that the adolescent brain responds differently to substances in the same quantities, and so, the adolescent brain is particularly vulnerable. And part of that is because of the way in which they process substances. So they seem to be less sensitive to some factors that might limit use, like, for example, the sedating properties of alcohol compared to adults, and then also seem to be more vulnerable to some more harmful aspects of substance use. So animal studies have shown more alcohol-induced learning impairments at the same level of use in adolescents compared to adults. Damage from substance use seems to more directly target those areas of the brain that moderate use in adolescence, so they seem to be more toxic to sort of the prefrontal cortex, which makes sense when we think that the prefrontal cortex is an area that's more immature and is rapidly maturing and undergoing really rapid changes during this adolescent period. There's also this notion of priming, so exposure to a substance during adolescence may increase the likelihood of addiction to the substance when you're re-exposed during adulthood. And so the big question is, we know adolescents that are vulnerable, they're sort of set up developmentally to be vulnerable to substances. And so it's important that we talk about them. And the question is, how do we do it in a way that doesn't seem like lecturing and actually sort of create space for them to share with us? So some general tips, and we can talk more about this during the question and answer period too. So I see adolescents alone and also with their parents. And I think it's really important to establish clear guidelines related to confidentiality. So legally, adolescents may be sort of allowed to consent to drug and alcohol treatment by themselves. But I think it's really important to think of, at what point do you want to bring parents into the conversation? And so what I always say is, as a physician, I'm seeing patients, and I'm sort of the teens doctor, and so I won't share anything that I hear from them unless I'm worried that it puts them in harm's way, and that they're sort of at risk for hurting themselves or hurting somebody else, and then I have to talk to their parents. I just say that to them and I say that to their parents, so it's really clear kind of what the guidelines are. Teens, we know that they're really egocentric, so often what's happening to them is the most important thing in the world. And so really sort of demonstrating to them that you are listening to what they say, using reflection, summarizing what they've told you using their own words, avoiding arguments. Young people can sometimes do a really great job of baiting their parents, and you don't want to fall for those traps. So really trying to avoid argumentation, using those motivational interview skills as best you can. I think if there's any way to find a way to connect through popular culture, music, sports, any way to sort of create a connection, a therapeutic alliance before moving into more sensitive topics. But what's important above all else is really to be genuine and authentic. And so, I think teens are really in tune to people who sort of respect them and take them seriously, but also know if that's not necessarily the case. If people say things, use slang, talk about popular culture, talk about substances in a way using terminology that's not familiar to me, I always ask. And so I think some of this is sort of cultural humility as well. When we think about how to address substance use in clinical settings, there are a number of ways to do that. And so we'll discuss sort of a case and follow this patient over about a year and a half of his life with his pediatrician. So David is a 16-year-old with a history of ADHD. He's taking Concerta and asthma, which is well treated. He's been getting C's in 10th grade, plays basketball on the varsity team. And so the question is, how do you bring up substance use with him? So there are a number of assessments that we do sort of when we see adolescent patients. There are different mnemonics. So one is heads, one is shades. But really this idea that the social history part of the exam is a really critical one for this group. And so not only do you want to ask about drugs, but you want to ask about sexuality, you want to ask about home life, school, activities, mood symptoms. And so, substance use is one part of many sort of sensitive topics you'll potentially discuss. And so, many times we talk about, starting with things which are less stigmatizing like home life, talking about how things are going with school, and then segueing into topics which are more sensitive, like sexuality, sexual history, substance use. Many clinicians sort of ask if someone's used substances and then sort of move on to the next question. And so, one of the things that I think is always important to ask is whether or not we should use formal screening instruments to ask about substance use. What is the best way to ask about substance use in adolescent patients? There's been some interesting work looking at screening instruments versus clinical impressions. And so, these are the sensitivity and specificity of medical provider impressions. So these are sort of trained providers making the diagnosis of any substance use in their patient, having a problem with substances, having sort of substance use disorder, or sort of actually meeting criteria for dependence. And what I think is really striking about this is that sort of specificity. So if physicians sort of make a diagnosis that a patient has a disorder or has a problem with substance use, they're often quite good at sort of that diagnosis. But it's not a very sensitive assessment. And so, only 10% of those with any substance use disorder are actually sort of picked up in the context of a clinical exam solely based on clinical impression. So very low sensitivity to identify those with problematic use or disordered use. And so I encourage providers to incorporate screening instruments into their clinical encounter as a way to identify substance use in adolescent patients. One of the most common ones is craft, and so you would ask if someone had ever ridden in a car by someone who was high or had been using alcohol or drugs. Do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? Do you ever use alcohol or drugs while you're alone? Do you ever forget things you did while using alcohol or drugs? Do your family or friends ever tell you you should cut down on your drinking or drug use? And have you ever gotten into trouble while you were drinking or getting high? And so the idea is that a positive score is 2 or higher on the craft scoring criteria. And when you think through and sort of look at these criteria, you can start to see, we're getting at some of the questions about using despite negative consequences, and getting a sense of, whether or not people are using kind of in more compulsive or uncontrollable ways. This is 94% specific. The positive predictive value is 83%. And we know that higher scores, so scoring 2, 3, 4, 5, 6, are associated with increased likelihood of dependence or more severe substance use disorder. One of my favorite sort of screening tools, and the ones that I used in my own practice, is the S2BI. And so, this is a screening to brief intervention and starts with one question. So in the past year, how many times have you used tobacco, alcohol, marijuana? And so if a young person says never, you stop. Otherwise, you continue with the second question. And the idea is if they say never, once or twice, monthly or weekly, you then score based on their response. And so the idea then, again, is that you start to get a sense of, based on this scoring, is someone likely to have no use, no substance use disorder, potentially be at risk for mild or moderate, or potentially, if they're using weekly, be at risk for severe substance use disorder. So in the past year, how many times have you used tobacco, alcohol, or marijuana? If never, you stop. If they say at least once or twice, then you ask about prescription drugs not prescribed to you, illegal drugs, inhalants like nitrous oxide, herbal or synthetic drugs. And this is a 90 to 100% sensitivity and 94% specificity. And so once you get the responses, you then, one of the things that I like about this is it sort of then leads you to the next step. So what do you do with this information? So if somebody says they've never used a substance, they clearly don't have a substance use disorder, and the focus of your intervention is really positive reinforcement to delay initiation. If they say they've used once or twice, unlikely to have a substance use disorder, and so you're going to offer advice that really sort of encourages ongoing cessation. Monthly use, you worry that they might have mild or moderate substance use disorder, and so your focus is going to be on delivering a brief intervention in the clinical encounter to stop or reduce use or risky behaviors. And then weekly use, you're worried they might actually have criteria for severe substance use disorder, and so the focus at that time is going to be on reducing use, accepting a referral to treatment, and potentially embracing medications for some young people. The American Academy of Pediatrics has a really nice clinical report with guidance on how to integrate this into a primary care setting. And so if we think back to our patient earlier, David, so he tells us he's never tried marijuana, alcohol, or tobacco. He's never ridden in a car with anyone who has. He says he's straight-edged and does not plan to use substances. And so for him, he's in this first category, so no use and really a focus on positive reinforcement to delay initiation. And so you want to give positive feedback. Many young people are hungry and eager for positive feedback, and so reinforcing this as a choice or decision. So you made a good choice to not use or not try substances. You want to use some motivational interviewing techniques. So I always ask, it's great that you haven't tried those things. What do you think has stopped you from using? And so, does he have friends in his peer group who use? We know that places him at potential risk. So then asking, how do you handle it then if you're at a party and someone asks you to drink? How do you resist that? And then reinforcing those positive behaviors. For some young people, particularly early adolescents who've just never been exposed to substances, you could say, well, how do you think you might handle it if you were at a party or one of your friends offered you marijuana or alcohol? How do you think you would manage that situation? And then can provide some additional support for how to negotiate those kind of conversations. Let's say instead David said he has smoked marijuana. He's never tried tobacco or alcohol. And so the question then next is, what other information do we want to know from him? So additional screening questions focus on a regular assessment of use. So how much do individuals use? Sometimes young people don't know quantity, but sort of asking about cost. So how much money are they spending each week on substances? How often do they use? How do they get it? Particularly as people progress to more severe substance use, sometimes you'll hear people reporting, transactional sex or other activities to pay for or fund their substance use. You want to talk about last use or first use, age of regular use, if people are using other substances at the same time. We know there's high comorbidity in general, but particularly in adolescents for mental health conditions. And so thinking of, are people sort of self-medicating in this population? Why do they use? They're obviously getting something from it, and why? What is that? And are there other potential strategies and ways to address that? Now, these questions not only help you make a diagnosis of substance use disorder and help you figure out, where people are in that spectrum of use, but you're also collecting information here that you're going to use later when you deliver your interventions. So I think it can be really helpful for young people because they don't necessarily think ahead. So if they're spending $100 a week, let's say, or even $10 a week, then at the end of the year, they're spending over $500 a week on marijuana. And so sort of talking through that. What else could you use that money for? If you saved up for 2 months, like how much money would you have saved and what could you spend it on? How many video games could you buy with that? Or would you be able to sort of put money towards the car? Helping them think through sort of other potential uses for the time or money that they're spending right now on substance use. We also think through family history of substance use or mental health. So we know that there's a significant genetic vulnerability. So about 60% of alcohol use disorders is related or associated to sort of genetic or biological vulnerability. And so if someone is engaging in high-risk alcohol use and has a family history of alcohol use disorders, then that sort of puts you at elevated risk and concern. You want to think through consequences of use. And again, young people don't always sort of make these connections. And so some of this is trying to get the information that you then will sort of provide back to them, kind of packaged in such a way that you can help them see some of these connections. And then as an adolescent sort of physician, I always think about sort of strengths. And so, have people sort of abstain. So I have a number of young people who may use marijuana heavily during the school year, and then in anticipation of summer jobs and urine drug screens, will sort of stop using in preparation for getting a summer job. And so that they're able to sort of leverage their strengths to abstain. Have people tried medication before? Do they have pro-social peers? So, do they have friends that they really enjoy spending time with who don't use substances? And can you figure out how to sort of leverage those relationships? Family support is really important. And we can talk about this later. I think families can sometimes be the greatest strength and also sometimes the biggest deterrent or hurdles to young people sort of getting engaged in recovery. And so getting a sense of what the family dynamics are like. So David tells us he smoked marijuana about 2 times in the past year. He last used about 2 months ago. He used it at parties with friends. He's never driven while high. And he tells you it's no big deal. Everybody I know does weed sometimes. I would never use real drugs. Marijuana is like medicine some places. It's like taking a vitamin. Everybody knows you can't get addicted to it. And so this kind of downplaying sort of potential risks associated with marijuana in particular is very common in sort of young people. And so what this tells us is he says he wouldn't use real drugs. And so, David in this scenario is making a risk assessment, right? And so we know, he's 16. He's sort of right at that range where he's starting to think through consequences. And so he's weighing risks and benefits now, and he's come up with the conclusion that there aren't a lot of risks associated with marijuana, and it seems like that's why he thinks this is a safe choice. And so we're going to want to sort of provide some advice. So he's in this category where he doesn't have a substance use disorder, but we want to provide advice to encourage him to continue to sort of not use and sort of stop using. One of the things that's sort of really important about this, particularly when we think about marijuana, is that there's this really sort of interesting relationship between perceived risk and past year use. And so this is looking at monitoring the future data from 1975 to 2013. And so this is a large national survey surveying high school students, similar to the Youth Risk Behavior Survey. And so you can see in the blue lines, it's past year use, and the orange lines are perceived risk. And so as the risk of the substance increases, past year use decreases, and the inverse is also true. So as past year use is high, perceived risk is low. And so really this idea, again, that young people do make a risk assessment. They don't always do it with all the information or come to the same conclusions that we wish they would, but there often is a risk assessment that's happening. And so part of the role of clinicians sort of in this setting is to sort of help sort of flesh out their understanding of risks of marijuana. So we know that cannabis dependence before the age of 18 is associated with an increased risk of persistent use. So if you start early, you're more likely to kind of use higher quantities and for longer periods of time. There's a greater IQ decline compared to adult onset use. declines in working memory and concentration, and we know that early onset use is associated with functional changes in reward processing. So how you process and interpret sort of rewards, particularly those related to substances. There's a great review paper by Nora Volkol in 2014 in the New England Journal of Medicine that kind of touches on a number of the short-term side effects of marijuana use and then long-term or heavy use. I will say that, this idea of addiction is an important one. So we know that particularly young people, but people in general who, particularly those using daily, can develop a withdrawal syndrome associated with cannabis use. And so, sometimes, and so it's sort of characterized for about 2 weeks after last use of being incredibly irritable, there's impaired sleep, and people just don't feel well. And so really this idea that sort of addiction or compulsive behavior associated with marijuana or cannabis use, it actually can happen, and it's higher in those who start younger, particularly in those who are using every day. You want to think about sort of what are salient effects for the young person you're talking to. So really thinking about, the impact on bronchial effects or COPD. So he has asthma, so maybe those things might be sort of significant for him. I've had a number of patients who sort of have noticed kind of weight gain and increased appetite associated with marijuana use, gynecomastia, you can see sometimes in young men. Young people sometimes are making poor decisions while intoxicated. So if you use condoms for sex, every time you have sex, except for when you're intoxicated, then that places you at increased risk. Thinking through the impact on school performance, again, school is sort of the primary job of young people. And so, are there things impairing their success at school? One of the things that we, I think sometimes it can be challenging for parents also to think of marijuana as being particularly problematic. And, part of this idea is that it's existed in popular culture for a long time. And so I think it's always important to talk about sort of the changing potency of marijuana or cannabis. And so this is looking at the THC concentrations, which is the active psychoactive component in specimens that were sort of seized by the DEA from 95 to 2014. Initial levels of about 4%, and this is sort of to 2014, levels about 12%. And so there's sort of a similar update in a study looking at data from Colorado, and the average sort of THC was about 18%. So really this idea that sort of potency of marijuana is increasing over time. There are also formulations that have very high levels of THC, and so dabbing, so this is a dab. It's really highly concentrated butane hash oil. People call it sometimes honeycomb or earwax, and really it's used by sort of vaporizing it and then inhaling really high levels of THC, so 70 to 90% in many of the products. Research has shown that users who report using dabs endorse more rapid tolerance. So they actually notice their tolerance sort of increasing more rapidly, and also endorse more frequent withdrawal symptoms if they don't use. There's been a really rapid sort of cultural shift with increasing number of states who have decriminalized and legalized marijuana for recreational use or medical use. One of the concerns is, not only, what does this do to sort of the perception of harm associated with marijuana, but young people with marijuana prescriptions report more kind of daily use or addictive use. And one study says, looking at those youth who qualified for a medical marijuana prescription said that they use marijuana because they're hooked more so than those who were obtaining the drug illegally. And so really this idea of, dependence and sort of daily chronic use in a very vulnerable group. So when David comes back to us, he tells us he smoked marijuana approximately 2 times in the past year. He last used about 2 months ago. He's never driven while high. He's used it at parties with friends. And so in this scenario, we want to give him brief advice. right? And so we want to sort of make the messages personalized and strengths-based. We want to focus on areas that are pertinent and relevant to him. So we get the sense from him that, he doesn't think marijuana is risky, and that's part of what makes him feel like it's okay to use. And so we want to be clear on the recommendation to quit. So I recommend you stop smoking marijuana altogether because, I know it seems like you feel like it's a safer alternative or it doesn't have a lot of harmful side effects, but I actually recommend you stop smoking altogether because we do know that, young people particularly are really vulnerable to the effects of marijuana before the ages of 25. And then you want to provide information on the effects that are relevant to the patient. So talking about, using marijuana can actually impact grades, decision-making, sports performance, and so on. And so try to figure out for David and for your patient, what are their motivations, what are they most interested in, and how is their substance use, or how might it potentially impact that. And then if we fast forward another 12 months, when David returns to see us, he's now smoking 3 blunts a day of marijuana to help him relax. He says he feels really irritable without it. He gets into fights. He doesn't think it's a problem. His mom is upset because he's now getting teased in school and she blames his smoking. He says, it's no big deal. I don't even think I have a problem. My mom is being overly dramatic. It isn't a problem for me. I could stop whenever I wanted. And so he's really in this category where we want to deliver a brief intervention, right? So he's past monthly, beyond weekly, and using kind of every day. And so we worried that he certainly meets criteria for substance use disorder. Brief interventions in adolescents last about 3 to 5 minutes, can be delivered in a routine clinical appointment. There's been a number of research studies that have shown that pediatric providers are effective agents to deliver interventions. You really want to focus on teachable moments or health context. So did a young person have a bad experience with substance? Can you sort of talk about that? Are there specific health things that are particularly impactful for the teen that you're seeing versus a legal or moral discussion, which is not necessarily a relevant thing in motivating change for young people. Studies have found that adolescents are receptive to screening and interventions by their PCP, and they have more positive perceptions of care when their primary care provider discusses substance use. So it actually makes them feel like they're cared for by their primary care provider. In general, you want to use self-guided behavior change strategies. So you want to help the young person identify, these are the things that I think I could change and think I could do, instead of sort of prescribing prescriptive behavioral changes. And research has shown brief interventions. Again, these are 3 to 5 minutes, so not lengthy interventions, but actually help reduce consumption and reduce sort of associated risky behaviors. So reduce driving, for example, while intoxicated. It could be its own talk or own day, really, to talk about motivational interviewing. But really the idea when you're thinking of this brief intervention is you want to get a sense of what stage of change is the patient in. And so in this case, David is pretty pre-contemplative. He doesn't think he has a problem with marijuana. His mom does, other people do, but he doesn't think that he does. And so he's really pre-contemplative. And part of our goal is to sort of move him to this contemplative stage. So can we have him think maybe he's using too much marijuana, or maybe his marijuana use is problematic? And then, if he's at that stage, we then want to say, can we help him then think of ways and strategies that he might start to sort of reduce his risk and then actually implement those in action. There are a number of motivational interviewing techniques to help David, but what we'll focus on today is really this idea of developing discrepancy. And so, part of what you want to do is get a sense of what is the teen doing. So when are they using? Are they having problems while intoxicated? Have they done anything they regretted while high? How often are they getting high, and how does that conflict with what they want to be doing? So some of these are more nuanced. So, they might want to get a job that summer. They want to go to school to study a certain thing. They want to play sports next year. Some of them are sort of, again, much more concrete. I want a job where I make a lot of money. And then you work backwards. Well, in order to get a job where you make a lot of money, what is your first step? Like, what do you have to do first? Well, probably go to school. What kinds of things do you think you need to study? If you're going to go to college, what kinds of grades do you need to get? And really this idea of trying to get a sense of, what is the future plan for the person you're seeing? What are their goals? And then help them see the contrast between what their goals are and sort of the behaviors that they're engaging in right now. And so an example might be, it sounds like you really want to go to college, but since you started smoking marijuana every day before you go to school, between 4th and 5th period, you notice your grades have gotten worse. You then want to provide some advice. So, only you can decide whether or not you stop quitting, whether you quit, but as your doctor, I recommend that you do. And then you want to educate. So we know when kids smoke every day, they're at risk for a lot of problems that can impact them at school, and then you would sort of talk through those. And so really it's sort of this format. So you'd want to summarize what you've gotten from them. So here's what you're doing now, here is what you want to be doing. And so sometimes, we know that young people don't always make those connections. And so part of what you're doing is packaging the information you took from them earlier when you were fleshing out their substance use history, and you're sort of putting it back to them in such a way that you help them start to see those connections. And then David actually told us he doesn't feel like it's a problem he could quit if he wanted. And I think you'll hear that over and over again in young people. And part of that is, again, sort of that egocentric state where they feel like they can do anything in some ways. And so, you want to kind of try to leverage that. And so, really it's this idea that you want to kind of create the challenge then. So I know you said you feel like you could stop marijuana use if you wanted because it's not a problem for you. How about you stop then for just 2 weeks? You can make a follow-up appointment to come see me, and then we can discuss how that went for you. And so, I think the benefit of this is, it can go one of two ways. So one, they quit during those 2 weeks, they come back, they talk to you about it. You can talk about whether or not they felt the same. Did they feel worse? Sometimes I've had young people who sort of realize, they are more irritable, and they do have this withdrawal syndrome. And, part of that we talk about is because they've developed an addiction and sort of dependency on these substances. And so really kind of unpacking that for them, and that can be eye-opening. If they feel much better, I think that also in itself can be eye-opening. If they're not able to quit because it's become something that they really rely on, then that can also be really crucial. And so, you want to discuss what the triggers were for use in those settings. And really part of this is planting the seed that maybe marijuana is a problem they can't control. And so you sort of take that challenge and they're successful at meeting it, or it sort of is eye-opening for them and in that it sort of lets them realize that this may be a problem that they can't control. And then when David comes back, so 6 months later, he's reduced his marijuana use, but he says that he started taking pain pills to help him relax and calm down after school. He says he first received a prescription for oxycodone after getting his wisdom teeth removed, and he uses about 90 milligrams a few times a week. He used to use them to feel good, but now he takes them to feel normal. And so that story of sort of, usually taking something and initially getting a high, and then that high decreases over time, and then eventually, because of tolerance and physical dependence, your sort of baseline state is one of withdrawal, and you take the substance to feel normal is something that we sort of see often, particularly with opiates, and that's sort of the sort of depiction of how the natural history of opiate use disorder. Because of limited time, I won't spend a lot of time going through sort of these slides, but you'll have access to them at the end of the webinar. What I think is important here is, the rates of heroin use are sort of low, 0.4 to 1.7%, but rates of prescription opioid misuse range from 4 to 14% depending on the study. We know that lifetime exposure, so these are opiates prescribed by physicians in addition to opiates used by friends or used illicitly, is high for high school students, so 22 to 45%. So there's lots of opiates that young people potentially are being exposed to. And so the story of David sort of taking an opiate that was prescribed by a physician that then triggered a problem is actually a really common one. We know that the rates of opiate use disorder diagnosis are sort of increasing, and so this is looking at data from 2001 to 2014, and we see really high rates in this 21 to 25-year-old age category. In this category, we'd really want to focus on delivering a brief intervention to reduce risk, accept referral to treatment, and embrace potential medications. And so this is sort of just unpacking that a little bit. So we'd want to deliver education sort of specifically targeted to reduce the risk of the substance. So in this setting with opiates, we worry about overdose risk, and so we'd provide knowledge and education about that. We'd want to prescribe, because this is opiates, Narcan or naloxone, which is an FDA-approved nasal spray that kind of blocks and reverses the effects of an opiate overdose. Prescribe to Prevent is a really great resource for providers who want information on how to deliver the counseling and prescribe the medication. And then we want to focus on referring for treatment and either treating in our current setting or referring for more formal substance use treatment. I also, at this point, when we're making referrals to treatment and we're sort of diagnosing really severe substance use, I always tell young people, now we have to talk to your parents, right? And so I think that idea is, I'm really worried about your opiate use and what you told me, and I think we really need to get your parents on board so we can figure out the best way to help you. So we can do that a number of different ways. I can tell your parents, you can tell your parents, we can tell your parents together. But before you leave for today, we'll have to let them know what's going on. And so, that provides some ability for the young person to decide how they want to have it happen, but also sets it up so you're not asking, is it okay if I tell your parents, or do you want to tell your parents? Many times the parents might know something's going on, but this may be the first time you're breaking that news. And so I think doing it in a clinical encounter where you're able to provide support is really important. There's a number of different medications to treat opioid use disorder. I will say, just as sort of an important caveat, is that a number of professional organizations support the use of medications to treat opioid use disorder in youth. There's evidence of efficacy. Small randomized trials demonstrate improvement in retention and abstinence in young people prescribed medications, and those are cost-effective. Naltrexone is a common medication that sort of is a blocking medication. It can be used and prescribed by any provider in a primary care setting, so you don't need specialty training. Buprenorphine is a partial agonist that does require that it be prescribed by a physician who's completed sort of waiver training through DATA 2000 legislation. We know that young people prescribed buprenorphine do better in treatment for longer, and longer courses of buprenorphine seem to do better. So there's no clear endpoint for how long young people should receive treatment with medications. And so really what's best for David is to engage him in a conversation about sort of what his goals are for treatment, what makes sense for him at his stage of life and with the resources he has available to him. There's no one strategy to treat substance use that works for every person, and so a lot of this has to be very targeted. I will say there's poor uptake of medications to treat youth with opioid use disorders. So 2% of adolescents receive treatment with medications compared to about a quarter of adults. Because this is the gold standard, it should be 100% for everybody, but there's definitely an age-related disparity. So I encourage people who are interested in learning more about this to reach out to SAMHSA or the Provider Clinical Support System, which is pcss.org. And so in conclusion, substance use is common in adolescents and young adults. Substance use and substance use disorders can be identified in primary care pediatric settings using screening instruments and careful history. And once identified, providers should provide targeted education, tailored brief interventions, and pertinent referrals to eligible youth. Pediatric providers and sort of clinicians in general have a really important role to play in the treatment of young people with substance use disorders. Thank you. I'm happy to take any questions.
Thank you so much. We do have a few questions that have come in, and if anybody has more questions, just keep sending them in to us. The first one is, do you know how much the number for cigarettes that you talked about earlier on in the presentation has gone down since about 5 years ago?
I don't know by what exact percentage point. I mean, I think what we've seen sort of happen, the trend that we've seen is that there's been an increase in from combustible tobacco or like traditional cigarettes to young people sort of initiating tobacco use with like electronic vaporizing products, so like vapes, so things like the Juul, for example. And so there's been an increase. The concern is, of course, and there's been studies that have started to show this, is that that then sort of leads young people to sort of move towards cigarettes or traditional combustible tobacco, and so that we might start to see that number increase over time. We haven't seen that yet. We do know that, it's been interesting looking at trends over time. And so, marijuana sort of has surpassed. So more young people report using marijuana than they report sort of using cigarettes. And that used to be true for African American youth, and now we see that that's true for white youth as well. And so, that sort of traditional combustible tobacco or cigarettes, those numbers continue to stay low. I do think it'll be interesting to see what happens with the increased publicity and sort of social media coverage and the increased number of young people who are using vapes and other products to consume nicotine now.
All right. The next question is, of all the screening questions that you talked about, are there particular questions that work best to begin with, such as engaging with the adolescent and not lose them in the conversation?
Yeah, I mean, I think in general, I usually will start off with a question when I'm talking about substance use. We usually talk about school, home, what kinds of things do they do with their friends. Ask about substance use, like do their friends use marijuana or alcohol? That gives you a sense of like what's happening in their peer group. And for some young people who may feel really nervous about reporting their use, it can sometimes be helpful to start with their peer group first, just so they can see kind of how you respond to that. And then I'll sort of move into a general screening question with the S2BI, asking about, how often they've used tobacco, alcohol, or marijuana. I mean, and again, I think, what's reassuring about some of the data from the looking at brief interventions is that young people say that they actually do want their doctors to ask about those things, and that they actually feel like their doctors care more about them when they ask those kinds of questions. And so I don't think there has to be the stigma that like young people don't want to talk about that with their physicians. I think they sort of expect, like in the context of a lot of medical information, that you're going to ask about those kind of behaviors. I think establishing a conversation about confidentiality before you even start talking about school or any of those other things can sometimes then remove some of the concerns that they have about answering honestly.
All right. Do we have time for a couple more?
I think so.
Okay. For teens with ADHD, is there current research that either correlates or refutes the connection between ADHD, which is untreated with stimulant medication, and an increase in SUD?
Yeah, so there is concern that there is increased, that young people with untreated ADHD are at increased risk for engaging in sort of substance use behaviors, and so that seems to be borne out. There is concern also too, stimulants are among the medications that young people can sort of misuse, and so, I think, so sometimes people do feel nervous about sort of treating ADHD with stimulant medication and young people who have endorsed using other substances, and so sometimes it can be a little tricky to just sort of figure out what is triggering what. The evidence, though, that does support that untreated ADHD is certainly a risk factor. Now, some work suggests that, that some of that may be sort of substance use dependent, but I think in general, the current guidance is really to sort of treat ADHD, even if that requires using stimulant medication, which seems to be most effective for many young people, even if they have another co-occurring substance use disorder. And young people who engage in illicit substance use and who I'm treating with stimulants for ADHD, I always engage in a conversation with a parent, so that's a medication that should be monitored by the parents. And so it's not like young people should necessarily be responsible for administering that medication themselves, but sometimes because there is concern about misuse and diversion, that it should be something which is supervised by parents.
All right, and one last one for today. Is there any data on drug testing in high schools and how that correlates to decreased drug and alcohol use?
Yeah, so in general, I would say drug testing, sort of all comers, or young people, for example, if a parent comes and wants to drug test a young person is a bad idea. And so, I think the important takeaway for drug testing is that it gives you a glimpse of a moment in time. And so, you might know for cannabis use, for chronic daily users, that would, you'd have a positive urine drug screen for about 30 days. For most other substances, though, you're really getting a reflection of, the past 3 to 5 days of use. And so even if you have a negative urine drug screen, that does not mean that someone isn't engaging in sort of concerning substance use. It means they just haven't used in the 3 to 5 days before you do the test. And so in general, we try to avoid, and there's sort of guidance to sort of avoid sort of administering drug tests in those settings. Now, if you're using a drug test to sort of monitor adherence to sort of drug and alcohol treatment, that's a different story. But in general, it's not something that we should be doing to sort of identify people who are at risk. The ideal way to identify substance use in young people is to talk to them about their substance use and use validated screening instruments to identify those who are at most high risk, in part because urine drug screens are not sort of a modality that can pick up any substance use in any population. It really reflects the most recent use.
All right. Thank you, everyone, today for attending, and thank you for all of your questions. Thank you, Dr. Wilson, for such a great webinar. At this time, I would like to go over our evaluation and CEU instructions. Everyone will receive a few emails from us following the webinar. You'll first get an email that's going to include a link to the evaluation and information on how to access your certificate of attendance and CEU certificates. Our evaluators are pleased to collect feedback from all event participants, and completion of the evaluation is critical to continue to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. Certificates may take up to 48 hours to appear in your profile, so again, we ask you for your patience. The second email you will receive will be sent around to all registrants by the end of this week or early next week, and will include a link to the recording of the webinar as well as PDF versions of the presentation slides. Again, we want to thank you for your participation today, and if you have any questions, please email us at info@ireta.org. Thank you, everyone.